These are my disclosures. So why transnasal endoscopy? What is the buzz with transnasal endoscopy? And hopefully you'll get a good feel for transnasal endoscopy after this seminar today. I'm going to start by showing some evidence for transnasal endoscopy. I'm going to talk about the difference between the transnasal scopes or the ultra-thin scopes compared to a standard endoscope. I'm going to show you some videos that demonstrate the technique, and we'll also have some patient feedback there because I think patient feedback is important. And then we'll progress to Tammy and Gillian's talk after that. So for those of you who are saying why transnasal, I say why not? Transnasal endoscopy can be performed in almost everyone. There's only one absolute contraindication, and that's hereditary hemorrhagic telangiectasia, or HHT. That causes torrential nose bleeding, and therefore it's best avoided in these patients. But transnasal endoscopy is a safe and well-tolerated procedure. It can be performed in our busy endoscopy units, but because it's so safe and the ease of setting up a transnasal service, it can be done in the community setting or in the outpatient setting, outpatient clinic, which a few people have also done. It's mainly diagnostic endoscopy, but there is some therapeutic uses for a transnasal scope. I personally find it very useful for performing esophageal stenting. Other things are for NG tube insertions, very useful. You can also use it if you've got an axios and a pancreatic pseudocyst. You can go through that to have a look if you wanted to have a look, see the debris in there. It's a quick technique and it's easily learned. It really isn't difficult and anyone can do it. So first question, do anybody here have experience of using transnasal scopes or have access to transnasal scopes in their unit? Okay, oh, we've got a 50-50 slip, okay. All right, so that's good. Okay, I'll slightly change. So most people don't have access to transnasal scopes. So hopefully you get the benefit from a seminar today. So what is transnasal endoscopy? As the name suggests, it's the passage of an ultra-thin endoscope down through the mouth to the back of the throat rather than through, sorry, down through, it's up through the nose to the back of the mouth rather than through the oral cavity. It has the advantage of not touching the soft palate, and therefore patients are less likely to gag and retch through the procedure. And it also allows patients to talk during the procedure, which I think is very useful in an anxious endoscopy patient. So what is the history of transnasal endoscopy? It was developed by Professor Shaker in 1994 to improve the tolerance and allow unsedated endoscopy. There was initial concerns regarding the inferior image quality and also smaller biopsy samples. And there was also concerns regarding the maneuverability of the scope. The scopes are thinner and more flexible, and therefore can be difficult to get out of a large baggy hiatus hernia, or if you've got a long J-shaped stomach, it can be very difficult sometimes to get through the pylorus into the duodenum. There was also concerns regarding the ability to detect small malignant lesions. And hopefully by the end of this seminar today, you will agree that the scopes have been developed so much over the last 20, 30 years, and we now have great high definition scopes that the image quality is superb on. So why would you consider transnasal endoscopy compared to standard OGD in your endoscopy unit? So we're all aware that unsedated endoscopy has an advantage over sedated endoscopy. It avoids potential side effects from sedation. It allows sort of patients that are higher risk, such as cardiovascular disease or respiratory disease, to have a comfortable procedure. There is less patient monitoring and also less recovery of patients and therefore it facilitates the movement of patients through your busy endoscopy units. There's no recovery associated with it, and therefore it can also potentially increase the number of points on a list. Ultra-thin endoscopy has significantly advanced, particularly in recent years, and we are going to demonstrate some of the new scopes today. Transnasal endoscopy is a safe alternative to OGD under throat spray, and it is more comfortable and cost effective. Although it's widely practiced in Japan, patient acceptance and tolerance is not fully established in the UK, although in Europe it's not established. However, in the UK it's gaining wide acceptance, particularly now after post-COVID-19. This slide just shows the comparison of a transnasal H190 endoscope compared with a 290 standard OGD scope. As you can see, the field of view is the same in both scopes, and the range of movement with the angulation is the same in both scopes. The main difference with the transnasal scopes, as you can see, is the distal tip diameter is, as you would expect, a lot smaller. It's 5.4 versus 10.2. And as a consequence of that, the working channel or the forceps channel diameter is less at 2.2 compared to 2.8 in a standard OGD scope. So what do we do at transnasal endoscopy? Patient preparation is key here. Tammy is going to speak about this, and therefore I'm just going to mention what we do and how we get the nurses involved. Our admission nurses don't just admit the patient, they also give a simethicone drink to aid visualization. They also are involved in the initial preparation of the nasal cavities, and they would ask the patient about which position they would like the scope to be performed in.
This is via the left nostril, and the patient is in the left lateral position. We will now just start the video, and you can see the nasal passage does appear to be quite tight. This video highlights the importance of orientating the nasal passages vertically, because once you do this, then you can get above the inferior turbinate nicely. That's the stacking tube opening there on the left, just gone past. That's the nasopharynx, and then that's back into the view that we normally see in endoscopy, and we're easily through the upper esophageal sphincter into the esophagus. And the patient is nice and comfortable there. As you can see, it's just slow, careful passage of the scope through the nose, and you try to avoid contact with the nasal septum because that is the most sensitive part of the nose.
I've got another video here showing how easy it is and how the patients tolerate nasal intubation very well.
In this nasal intubation video, you can see that it is fairly easy to negotiate the turbinates. That's the stacking tube opening there on the left, and then you just rack up, and then that's into the nasopharynx, oropharynx, and that's the view that you're used to, and you can easily get through the upper esophageal sphincter. And the patient is nice and settled, no gagging, retching.
It's also important that there's concerns not just about putting the scope in, but also withdrawing the scope. So we have a video showing that.
This video demonstrates the withdrawal of the T&E scope, as I think this is just as important as intubation of the nasal cavity. You can see the image quality from these scopes is superb, and I personally do think that we pick up more upper esophageal pathology, such as inlet patches, as the procedure is so well tolerated. The scope is gently withdrawn up past the upper esophageal sphincter. The scope is gently racked up to give good views of the oropharynx, and I personally get the patient to say E and A during this part of the examination. As you can see, the fossa is better seen during this assessment, and it gives me confidence that I've given the patient a good examination of their oropharynx. I think this is good clinical practice.
Those videos, along with others, are available in the Resource Centre for you to further view at your leisure. So moving on to a poll, what do you perceive to be the most advantageous part of transnasal endoscopy? Those options are coming in now. Is it patient comfort? Any other suggestions? Patient safety, perhaps, might be considered. Void of sedation. Less gag, yep, I would agree with that. So,
Norma,
yep.
while we wait for people to answer the poll, do you think, besides quicker inpatient comfort, have your patients given you any feedback about the parts they find most advantageous?
Yeah, a lot of patients we get is mainly got to do with the gagging. It's the less gagging, they do find it more comfortable, particularly the ones that have had the standard unsedated OGD. And a lot of anxious patients like the fact that they can talk during the procedure. It doesn't take that away from them. They can communicate well, because the fear is if they don't tolerate it, they worry that they can't communicate with endoscopists and get them to stop if need be. So that's quite a good advantage from that. Okay, so I think the majority of people are thinking patient comfort. I would certainly agree with that. Happy to move on from that now. So what are the main concerns raised about transnasal endoscopy? A lot of us will say, well, why change our clinical practice? There is concerns regarding the scope itself. It's a small, thinner scope, and therefore, is it as durable as a standard OGD? As mentioned earlier, there's concerns regarding image quality. There's concerns regarding the smaller biopsy channel, and therefore, does that mean that there's less suction, etc., available? And there's concerns regarding missed pathology. There's also concerns regarding patient safety. What are the main risks with transnasal endoscopy compared to standard OGD? What about patient tolerability? And there's concerns about the procedure itself. I mean, what training is required for transnasal endoscopy? Can anyone do it? So looking at the scope itself, this is images which are kindly by my colleague, Dr. Sergio Koda, and these are just still images from the new Olympus HD scopes, the current generation scopes, that you can see how nice the images are, how crisp HD image is. You've also got the benefit of additional imaging modalities, such as narrowband image, as seen on the middle picture here. And in the end picture, Sergio has put down some acetic acid just to further identify the Barrett segment there. So as you can see, it's nice, clean, crisp images there. I have no concerns regarding sort of image quality with the current HD scopes. What about evidence for transnasal endoscopy? Looking at some meta-analysis, this study published in 2015, so it is published a while ago, and it looked at 34 studies. It involved just over 6,500 patients, so significant numbers. And you can see that the success rate for transnasal endoscopy unsedated was quoted at 94%, and then that increased to 97.8% if the transnasal scope was passed orally. I think we have to remember it is an old study, therefore it involved old scopes, and I would certainly suggest that the current success rate with transnasal endoscopy is much higher than that. They also suggested that only 63% of patients preferred unsedated transnasal endoscopy over a standard OGD. I would actually suggest that that's probably about 98-99% in our patients that have transnasal endoscopy. This other study looked at 22 prospective randomized controlled trials comparing transnasal endoscopy to sedated and unsedated standard ODD. There were slightly less patient numbers in this study, in which was less than 3,000. But you can see the success rate for standard ODD was again measured to higher than transnasal endoscopy. But again, I think that's got to do with the scopes along with our technique. Sort of the technique of transnasal endoscopy has certainly changed and developed over the years, and I've certainly changed my transnasal practice over the 6 or 7 years that I've been doing this. The authors, however, concluded that transnasal endoscopy was significantly more comfortable than unsedated standard ODD. It was associated with less gag reflex and nausea compared to unsedated standard ODD. The patients did have a longer procedure time, but the recovery was shorter versus sedated standard ODD. After transnasal endoscopy, the patients can really get discharged after they've had their paperwork. I think having a longer look is not a bad thing, as advertised by sort of BSG. The longer you look at something, the more likely you are to pick something up. And sometimes the longer look can increase in 2 times 3 increase sort of chance of picking up significant pathology. So it is important that we take time and have a good look at all areas of the upper GI tract. Transnasal endoscopy patients have a lower heart rate and lower systolic blood pressure during the procedure. And therefore, the authors concluded that transnasal endoscopy was superior to unsedated standard ODD for comfort, cardiovascular distress, and recovery duration. In this study, this is an Edinburgh study by my colleague, Professor John Pleveris, I was involved in, looked at 157 patients that were randomized to transnasal endoscopy versus standard unsedated ODD. And looking at how well the patients tolerated this, they got asked to record a gagging score. And as you can clearly see here, the gagging score for the transnasal group is significantly less than the standard unsedated ODD group. For those patients that reported a gagging score of 0, i.e. no gagging, this was significantly higher in the transnasal group. It's 70% compared to 26% with the standard ODD scope. So what about overall comfort? You can see in the transnasal group, the scores were higher, both at the time of initial endoscopy and also when the comfort score was recorded 7 days post-endoscopy. And what about patients being asked what they would prefer in the future? Again, a large majority of patients were perfectly happy to have transnasal endoscopy again. There was only one patient that was very reluctant, and they were a failed transnasal endoscopy due to altered nasal anatomy. This is another study that just confirms tolerability, looks at various studies here. And as you can see, the clear message is that transnasal endoscopy is more acceptable. It's better tolerated. There's less choking and gagging. So moving on to concerns regarding biopsy size. Does this translate to being clinically relevant? With the transnasal scope having a smaller working channel, you have to use smaller biopsy forceps. You have to use pediatric biopsy forceps. So therefore, we are going to get smaller biopsies with that. Biopsy size from transnasal are generally 1.8 millimeter compared to 2.2 millimeter with the standard ODD biopsy forceps. But they are comparable thickness, and that's what's important. So therefore, smaller size did not significantly affect diagnostic performance. And indeed, there's some studies that suggest that transnasal endoscopy may provide better diagnostic performance in some cases, such as the diagnosis of short segment Barrett's epithelium. Patients are better tolerated, they're not gagging and retching, and therefore you can have a good look at the epithelium lining there. What about safety concerns regarding transnasal endoscopy? There's no major complications reported apart from one case of perforation, and I'm sure you'll agree that that's substantially less than the perforation associated with standard OJD. The most frequent side effect that is reported is epistaxis or nose bleeding. It's quoted in the literature to be around about 1 to 5%, but I think in clinical practice this is much less. And indeed, I would probably say it's at less than 2%, if that. I can count on one hand how many problems I've had with epistaxis over the thousands of transnasal endoscopies that I've performed. Some of the side effects include nasal pain, but you can always stop mid-procedure, take the scope out and address that, prep the nose, anaesthetize the nose better if the patient is uncomfortable. It's important to chat to your patient during the procedure. We've had 1 or 2 cases with sinusitis. It's quoted at 1%, but again, I would suggest that this is higher than what we see in clinical practice. In a few cases, there was issues reported with withdrawal difficulty, and that's mainly those with a tight nasal septum. So what training is required to undertake transnasal endoscopy? There's JAG guidance issues regarding transnasal endoscopy in 2018. It was recognised that there was no formal training programme, but there should be a requirement to understand the nasal anatomy and how to deal with complications such as epistaxis. It was also recognised that there were subtle differences to negotiate the large hiatus hernia and passage into D2. Comment was made that the ENT team should be involved at local service level, and I certainly cannot stress that enough. I think it's important to involve your ENT team early and encourage them to get involved and help you support the service, because I do think you get better views of the oropharynx and nasopharynx, and therefore you do pick up some ENT pathology. You don't need to know what it is, you just need to know there's some asymmetry there. Take some pictures and fire that off to your ENT team and let them deal with that. The JAG guidance suggested that you should participate in training courses, such as this one sponsored by Olympus. So what about competence? For those that are signed off in upper GI endoscopy, what sort of training do you actually need? This is a nice paper from 2007 in which it looks at trainees competent in OGD with sort of transnasal endoscopy experts. There was no reported difference in the technical success or the epistaxis rate or the willingness to try. It was therefore suggested that transnasal endoscopy can be performed from the first case, but it takes about 30 cases before you develop what we call skillful hands. And that's really probably getting used to the different manoeuvrability of the scope. We could perhaps ask Tammy about how she learned her transnasal endoscopy and her opinion on that with the competence for transnasal endoscopy at the end of her talk.
It was a lot better than having it down the throat, because when I had it down the throat, I felt uncomfortable. That was quite straightforward.
No problem whatsoever. That was easy.
It was all straightforward, quite simple, always reassuring, and it was all over in what, 10, 15 minutes?
It didn't bother me at all when I was actually dreading down the throat.
So much better than getting it done through the throat.
Easily, definitely. Much better. A lot easier.
Yeah. Oh yes. Oh yeah. I wouldn't do it any other way. I don't really want to have it procedure done again. But yes. No. It's no problem at all.
I definitely recommend it to them, because I mean, even yesterday I was speaking to a friend and he said I had it down the throat and he said it was terrible. So that was great. There's no problem at all.
Yes, I'll be begging them for it. Don't ever want to get cameras down my throat again.
I'm sure you'll agree, I think the best advocate for transnasal endoscopy is our patients, and that video just summarised some patient feedback that we've had with patients with a transnasal endoscopy. I think no talk regarding endoscopy would be complete these days without mention COVID-19. I'm sure that most of us here are aware of the impact of COVID-19 has had on our endoscopy practice. You're aware of this study published in Gut last year that looked at figures from the National Endoscopy Database. They estimated that early in the UK sort of lockdown, when endoscopy activity was ceased and reduced, we were down to approximately 5% of our normal activity. And then 10 weeks later, we were only increased to 20% of pre-COVID levels. Currently, we're not yet, so certainly my unit, we're not yet back up towards where we were pre-COVID with regards to list numbers, but we're certainly getting there, and within the next few weeks we will be there. I know several other units that have just sort of gone back just recently to the pre-COVID endoscopy levels. As you can see from the table here, you can see that it's estimated that there was an 86% reduction in activity compared with pre-COVID upper GI endoscopy numbers. This is just highlighted in the graph here. OGD numbers are in the yellow sort of line, and you can see how it dips down and it's still slow to recover. So how can we recover our diagnostic upper GI service? We'll all be aware of waiting times, and I do think that transnasal endoscopy is a solution to that. So how can transnasal endoscopy aid endoscopy recovery? As demonstrated, I think the tolerability is much better, and therefore you have less number of failed procedures. This cuts down the need for repeat procedures, and therefore it protects our valuable endoscopy slots. The risk of coughing is reduced with transnasal endoscopy, and therefore aerosol generating spread is reduced, and therefore is that safer for both patients and staff in endoscopy. In my trust, NHS Lothian has currently deemed transnasal endoscopy as non-aerosol generating procedures, and therefore allows us to increase capacity. Transnasal endoscopy reduces the need for downtime during procedures. There is less use of suction, etc., and therefore can increase capacity on our lists. It can easily be and safely implemented in the community setting, and Jill is going to highlight this in her talk later on today. This is important so that we can get the large number of diagnostic endoscopy out into either outpatient setting or in a community setting, so that we can use our busy endoscopy units for more sort of advanced or therapeutic procedures. There is no need for additional recovery space for transnasal endoscopy patients. They can be discharged safely once the paperwork is given. And this is again safer for both the patients and staff, but it also allows us to get more patients on the list. It takes away the headache of recovery space, which you get with sedated OGD when you have to adhere to social distancing. In conclusion, transnasal endoscopy has transformed our endoscopy practice in the community setting. It's a safe and potential cost-effective alternative to standard OGD. There's no side effects related to sedation. There is no post-procedure monitoring, and therefore there's minimal aftercare for the patients. Hopefully we've demonstrated that there's been excellent patient tolerability with increase in patient comfort and reduced gagging with less cardiovascular stress. The transnasal endoscopy scopes have reliable diagnostics, and they have lovely HD images now, which improves our endoscopy performance. Transnasal endoscopy can be performed by any trained endoscopist, and there's only minimal additional training required for any JAG accredited endoscopist. I hope you'll agree that transnasal endoscopy is a valuable tool which can easily be implemented to aid endoscopy recovery post-COVID-19. Thank you.